And how's the weather in the UK?
It's not too bad. There's no snow at the moment. It's just a bit kind of wet, a bit cold. Nothing major so far. You know, I mean, the days of the bad snow and things we haven't had bad snow for a long time.
Not a white Christmas.
No, well, legally it was because there was some snow. So yes, if people are betting on a white Christmas, I think they would got some money, but no, it wasn't white where we were.
Okay.
Right, let me just try and minimize the picture so we can see most of the slide. Can everyone see that okay?
Yeah, it's perfect. I think.
Are you happy for me to start, or you want to give a few more minutes?
I think we can start.
Okay, cool.
First of all, I'd like to thank you for joining us for, I think this is probably the 4th time.
Oh, at least.
And I also saw you present at a conference in the Emirates a few weeks ago. I logged in and saw you presenting.
Oh, thank you. That was, but I think it was about cholangiocarcinoma. Was it cholangiocarcinoma I was talking about, or was it liver mets? I can't remember. Anyway, last year we discussed about very specific tumor types. We talked about colorectal cancer, we talked about sarcoma, we talked about other primary liver tumors. But today I thought we should do is to have more of a non-clinical talk. So this is more of a talk about services and how to set up services, and in particular about the tumor board and the importance of that, because obviously that's where all our decisions are made. So please bear with me. There won't be many pictures of operations today. So in terms of the multidisciplinary management of cancer, and obviously, you know, I'm involved with both the British Association of Surgical Oncology and the European Society of Surgical Oncology, and I came to Cairo last year to talk to the Egyptian, Society of Surgical Oncology. And as surgical oncologists, our main discussion point is around multidisciplinary care. We're not just about the technical aspects of how to do an operation. Now, multidisciplinary care of management of cancer was quite controversial when it was first proposed, but there is good evidence that this type of way of working can improve survival of patients. And in a lot of countries, certainly in the UK and a lot of European countries, it is a legal requirement that all cancer patients are managed within this tumor board scenario. And if you look at this definition of what that tumor board consists of, and this is a really good definition from the American College of Surgeons, it talks about a cancer committee, which has physicians, which both have a diagnostic but also a therapeutic role, as well as non-physicians who support from the administrative side and coordinate the care for the patients. Now, what I want to focus on a bit more is this concept of human factors. Now, what are human factors? Well, we know when you look at errors, okay, not just medical errors, but any errors, the vast majority of these errors are related to human factors. And this can be at an individual level, a pilot, for example, or a surgeon. It can be at the level of an organization, but often it's a combination of both. It's a combination of an individual problem, but also a system that puts that individual in a position where an error happens. And so what are human factors? So the human factors are really principles and practices that are aimed at optimizing human performance through a better understanding of our behavior and our interaction with the environment. And this really is a talk is about the importance of non-technical skills, okay? And where do these non-technical skills and this concept comes through? Well, it comes through the airline industry. Every time, you know, there is an air crash or some disaster, we don't go and blame the pilot or the airline or whatever. What we do is we try and learn from that error and put in place processes that prevent that error ever happening again. So it's a positive way of improving safety. And it's all about allowing us to have safe and effective performance, okay? Now, what about the MDT, bringing it back to the kind of medical area? So when we talk about an MDT, it's a multidisciplinary team, okay? You can call it a tumor board or whatever you want to call it, but it's essentially a team of people. So what is the definition of a team? A team consists of at least 2 or more people who interact, and they have a common goal. And within that process, they have specific tasks or roles. And the key thing is that they have complementary skills, and they're committed to common purpose and hold themselves mutually accountable. So for these teams to be effective, they need to be committed. Now, if you look at most tumor boards, you know, we have very specific regulations about attendance at a tumor board, but certainly in the UK, that attendance has to be at least 75% of the time the tumor board is constituted. Some people will be there more, some will be less, but at the very least, you need to be at least 75% of the time. Obviously, you need to have a common goal, and in this case is improving patient outcome and hopefully survival. You need to be competent at what you do. You need to have a consistency of performance. You need to be able to communicate within this meeting, obviously. So when we look at effective teams, these are the key elements of an effective team. The people within that tumor board have to trust each other. Feelings have to be openly expressed. So if you think someone is making a wrong decision, you have to challenge and you have to be open about it. If there is conflict, you work through that. People will support one another. Information is freely shared, and our objectives are common to all. And certainly in the medical scenario, it's about improving patient outcomes. But there is another type of way of working, and these are called cooperative groups. So here you have people that work together. Feelings are definitely not a part of work, okay? Conflict exists, but it is accommodated. Trust and openness are measured, okay? You don't give anything away. And information is only given on a need-to-know basis. And the objectives and goals are either personal to you as an individual or they're unclear. Now, if you go back and reflect about how you know, we work within our individual hospitals, and you look at how teams versus these cooperative groups work, you know, I suspect a lot of people will probably think they don't actually work within a team, they work within this other thing called a cooperative group. And this is an example of a high performance team. Obviously, I'm a fan of Ferrari. And so this is an example of a very effective racing car team. Currently, it's obviously Mercedes-Benz, which is at the top, and Red Bull Racing and things like that. And in medicine, we do also have high performance teams. Well, this is an example. So this is a trauma team role. And the key thing is that the team leader has situational awareness. Okay, so the team leader is not actually doing anything physical. Okay, they've got an overview of everything that's happening. And this is an example of a kind of triage situation in the military setting. And there is the trauma team leader standing back from the patient and directing the process. And why I'm mentioning this is that it is important when you set up your tumor board, even the placement of the tables and the chairs and the screens can influence how we work. Okay, and this is an example of how the room is set up in Liverpool. And generally, you know, the decision makers have an overview of the patient data. They're not sitting there trying to read notes and take notes and things like that. So they are presented with information, and then they see the scans. The decisions are then made, and crucially, we use a electronic record system for our tumor board outcomes, and these are scribed and annotated by the coordinator in real time, and we can confirmed that we're happy with our outcome before it is locked down. So it's about, giving those people who are making the key decisions, enough space and time to make that call without having to do 3-4 different tasks. Now, decision making is crucial because the MDT is essentially a decision making machine. So what is a decision? Okay, so decision making is a process of reaching a judgment or choosing an option, okay, to meet the need of the given situation. And there are a number of elements in decision making. You have to assess the situation. You have to then generate a number of options. You then have to select and implement an option. And crucially, you have to then go back and close the loop and review your outcomes. So this is an example of a very straightforward case of a man in his 50s who's had a resection of a rectal cancer, who then develops liver metastatic disease, something that we deal with many times every week. But if you actually look at the process, each of those red circles is a node. Each of those things are different options. And the first bit is about, local staging and diagnosis. That's the situation assessment. Then you have to do is to generate a series of options, which would be ranging from chemotherapy, whether it be neoadjuvant or palliative, surgery, imaging, whatever, okay? You have to then select an option, and crucially, then you have to review the outcome. So even a very straightforward case like that, the process behind that decision is very complex. And it's important to recognize the role of the surgeon in the tumor board, because surgery is a cornerstone of treatment of the majority of solid organ cancers. It's really the only curative option for the vast majority of cancers. And this is why the surgeon is crucial and often plays a leading role within the tumor board. Now, the other key thing to remember is the tumor board is not just a meeting, okay? So, the decision don't have to be made on a Thursday afternoon. If there are crucial decisions to be made, you can constitute this group of people on an ad hoc basis. Now, I want to now move on to the role of the MDT, or the tumor board lead, So what are the qualities that are required for an effective team leader? The first thing is strategic thinking, okay? You need to have a vision. You then need to be able to communicate that vision to everyone else. People will not always be happy with your vision. They will want to change it, or they'll have a different proposal. So you need to be able to negotiate. You need to be able to organize yourself. But when a decision has to be made, you have to be decisive. You need to facilitate other people as well. So it's not just all about yourself. Obviously, you need to be motivated. And crucially, you need to be good at time management. And certainly most doctors are not great at time management. That's why we're having this discussion at 9 o'clock Egypt time. So what is the major role of the MDT, or the tumor board leader? It's not to sit at the front of the room and say, this is what I'm going to do, and then everyone else is keeping quiet, okay? That's not what it's about. It's ultimately about this. It's about quality assurance. So what is quality assurance? Quality assurance is a complete, Quality assurance is a complete set of systematic actions that are required to achieve a treatment result that meets a certain quality standard. So that's the key thing, is meeting a certain quality standard. And quality standards are a set of specific, concise statements that act as markers of high quality, cost-effective patient care, okay? Now, I'm working in the NHS, which is a very socialist healthcare system. It is all based on evidence and value for money, okay? And these quality standards are derived from the best available evidence. So certainly in our country, it is like the NICE guidance. And a lot of other countries also use the NICE guidance as a resource. And these are produced kind of collaboratively with partners, service users, and carers, and crucially patients are also part of this process. And the purpose of a quality standard is to make clear to everyone what is the definition of high quality care. This then allows you to support benchmarking of performance, and crucially to provide information to patients and carers and the public with the quality of care they can expect. Okay. So when NICE develop quality standards, this is the process. So first of all, they choose a topic. They're not going to choose very rare things. They're going to choose things that are common and things that are important to healthcare. So this requires them to then provide evidence. So they get evidence either from NHS or other resources. They go off and do a very broad literature review. So from this evidence, they generate some guidance recommendations. These can then be distilled into quality statements, and this can then produce some quality measures. Okay. So are we able to then compare outcomes between different hospitals and organizations? So if you look at in the UK, there are these HPB quality dashboards, and these were produced a long time ago. And there are a number of benchmarks there. You don't need to necessarily read them all, but what you can then do is to set a kind of a median or an average value for all hospitals in the country. And then what you can do is either be on the green side, which is good, or on the red side, which is bad. And then the diamond there shows you which hospital, what the your own individual hospital is rated as. And if you look at a lot of these metrics, and this is looking at, say, pancreas cancer, you can see, you know, there's very little variation. Everything's okay. In liver cancer, unfortunately, I'm a liver surgeon. Certainly, this was a few years back, but there's a lot of variability in terms of liver surgery. And you can see also this internationally. So this is data from an old trial called the Crystal trial. This was looking at the use of cetuximab or Erbitux in patients with being managed palliatively with metastatic disease. And these were the liver resection rates across all the centers and countries in the study. And you can see that this data looks strange. And that's because the lower bar there, if you were to put a metric of liver resection as a quality metric, well, all those centers in the countries there, the liver surgeons were never involved in the decision-making about liver surgery. And so the resection rates in the trial for those patients was very low compared to those other centers, okay, in the countries. So you can see how if you have a key member of the tumor board not as part of the process, and this isn't a clinical trial, then it has a big impact on a metric, for example, liver resection rates in this clinical study. So I want to take you now to what we do in Liverpool. And we've developed this advanced colorectal cancer tumor board quite a few years ago. So when you look at management of stage 4 colorectal cancer, there are a number of treatment options here. In fact, there's more now because even liver transplantation is being considered. And there is, you know, at least 2.5 million possible permutations in the management of advanced liver-limited colorectal cancer. And when you look at these patients, they're often managed through a local tumor board, which is colorectal based. They might then be referred to HPB tumor board. And if they have lung mets, then they're referred to a thoracic tumor board. And across the UK, the HPB tumor boards are either incorporated into generic upper GI MDTs or tumor boards, combined liver and pancreas tumor boards, so you have a huge variation of cases to discuss, or separate liver and pancreas tumor boards. So the limitations is that, you know, often when these patients come to your tumor board, they may have inadequate information, clinical information. There is generally no input from a colorectal surgeon or a thoracic surgeon in terms of making decisions about the primary tumor or the lung metastatic disease. There are often no clinicians present who have a direct knowledge of the patient. And this can often lead to delays in the management of these patients. Now, again, you could probably see in the UK, you know, everything is very regulated. And so this is a manual that was developed a while ago for setting up a cancer service, okay? And it tells the people who deliver the cancer service how to set things up. So the cancer networks, each part of England has a cancer network. So the responsibility of the cancer network is to set up these services. And what they need to do is to meet nationally agreed guidelines. And it's important that as part of this tumor board, they stage the disease and assess the patient fitness. And often this doesn't unnecessarily happen. And so this was another factor that was a problem. Now, what we did in Liverpool a long time ago was not focus just on the site of the disease. It's in the liver and needs ALPS, or it needs a two-stage resection, because that's a lot of what liver surgeons like talking about. But it's really to focus on the overall burden of disease. So which patients do we want? Well, we wanted all patients with liver limited or with limited extrahepatic disease, so for example, low volume lung metastatic disease. Also crucially, all patients presenting de novo in stage 4 disease. And as I've mentioned, all patients are potentially resectable lung mets. And the key thing is, within this tumor board, all specialists involved in the treatment were present. So we could appropriately stage and manage patients who had stage 4 disease. We could plan treatment and reassessment after completion of initial treatment, because often the initial treatment is systemic chemotherapy when they present in stage 4 disease, unless they've got a symptomatic tumor that needs an operation or a stent. And crucially, communication was improved between all the specialties. And also, it facilitates recruitment into clinical trials. And so these are the team members. So we have obviously liver surgeons. We have only one part of the team. We have medical oncologists. We have pathologists. We have a PET radiologist. We have a cross-sectional radiologist who, you know, has an MR interest. Interventional radiologists, if you're thinking about ablation. We have an anesthetist who can then assess patient fitness as well. We have a colorectal surgeon and we have a thoracic surgeon. I think palliative care input is important, but we don't currently have anyone from palliative care within our tumor board. And crucially to all this is a specialist nurse, and the patient is in the center of this process. So this tumor board was commenced back in 2013, so it's almost 8 years now. In the first 2 years, we reviewed 276 patients with stage 4 disease. 107 had their primary in situ. So these are patients who had synchronous disease. The primary still was in situ. The other patients that we had also discussed between the referral and tumor board, etc., the primary would have been dealt with. But crucially, about half of the patients that came with the primary in situ, the intention of the treatment was curative intent. So we increased the number of patients discussed at our tumor board over this period of time. Time for each discussion also increased, not surprisingly. There are more people, more options are being discussed. But crucially, there's a median of 1 discussion per patient to reach a treatment plan. And in the UK, we have cancer pathways, and there are no breaches of any of these cancer pathways. And the focus of this was on patient outcomes. And this is a very old paper back from 2014 when we initially started the process there. We really should go back and visit that because now we have many hundreds who've come through this. So in conclusion, not one individual can make all the decisions in isolation. That's important to remember. For optimal outcomes, there is need for effective tumor board working. Effective tumor boards require the qualities of a high-performance team, and the major role of the team leader is not to tell people what to do, but is actually quality assurance of that team. Thank you very much. I think that's all I've got to say. That was about 25 minutes. So it might be a bit controversial, so I welcome your views and comments.
Thank you. I'll start with a question from my end. So you mentioned that in your MDT there are like 12, maybe 12 specialists, like, or 12 different identities. Like, what is the minimum? I mean, every time do they all have to attend, or like, what would you call the minimum?
We want. So there are core members and extended members. The core members.
Yeah, exactly. Who's the core?
Yeah. So core is liver surgeons, radiologists, oncologists, our specialist nurses. So the people based within our hospital are the core members, although the oncologists they attend our tumor board, but they're employed by different hospitals. Not really, so we can't force them to stay, but they're part of it. So they're the core members. And then you have the extended members, which are the colorectal surgeons, the thoracic surgeons, the interventional radiologists, etc. And so their attendance is a bit more ad hoc. But so, for example, the patients with rectal cancer are the ones that there's often most discussion and debate about, because you have what are the options of stage 4 rectal cancer? Well, you have to stage the primary. Is it margin threatened? Does it need radiotherapy? Are you going to go with short course? Are you going to go with long course? What's the burden of the systemic disease? Is it in the liver alone? Is it in the lung? Do you need systemic chemo? How do you then sequence radiotherapy, chemotherapy, surgery? So all those discussions are often, you need the colorectal surgeon in the tumor board. Now, when we set it up, we have about 15 to 20 hospitals that send their referrals to our tertiary center. So anyone who needs a simultaneous resection, they're done in our center with our colorectal surgeons. So when we set this process up initially, we had surgeons from all the other centers able to come, and it was an open invitation. 2 or 3 people said we will be interested in supporting this. They started attending the tumor board, and then they rotated. Other people came, etc. But they can give a colorectal opinion. But if they need an operation in our center, it'll be our surgeons who will undertake that. And that can be slightly politically, it can be a problem, because some people might think, oh, these guys are trying to steal our cases, but it's not. If you're going to do simultaneous resection, I can't go out there and operate in a small hospital doing a liver resection just because, so if it's going to be simultaneous, it has to be done in our center.
Okay, and you mentioned that in the middle of this diagram, you put the nurse and the patient. Does the patient attend the MDT?
No, and this is one of the issues. So if you talk to a lot of patient charities, they feel the patients, should have some form of involvement in the tumor board, but you can understand because of confidentiality and things that isn't possible. But the patient nurses, the specialist nurse is often the patient advocate in that position. I think there's a few questions there.
Okay, Dr. Wael, we have a question, Dr. Wael.
Good evening, Dr. Hassan. This is Wael Gawadi speaking. Happy to have you in the meeting. I just have a question. In the tumor board presentation, usually the most responsible physician present his decision to be discussed in the board. So how frequent is the single physician decision changed after discussion in the tumor board?
Okay, so I think the thing to remember is that, so legally we have to discuss all our cases in the tumor board. That's a legal prerequisite. And the way we do things is that the responsible clinician, for example, they will do the outcome. Okay, so we'll have so our juniors will present the case. We generally have 4 liver surgeons there. They will discuss options, etc. And then the responsible consultant or clinician, whose case it is, will then take an overview of that discussion and then present that as the outcome of the case on the electronic system. So the scribe, who is a administrator, will type as you're talking, and then you will make sure that you're happy with all the wording, because that's then a legal document that then goes into the notes. And there is a debate and there's a discussion, you know. So for example, I might have a patient, I think, yeah, we need to crack on and operate. My colleagues say, well, you know, no, maybe more chemo or this, that, next thing. And so that is an open discussion, and it's a kind of bit of a majority view. Generally, we all agree, but not in every case, for example. But the other point to make clear is the tumor board is advisory. Okay, so when you then go and see that patient in the clinic, and you say, well, this is what the tumor board said, it is an advisory process. And then if the patient says, look, I don't like this, I want something else, whatever, then, you know, you can take that into account, and you may, you know, as long as there's a good reason, you may then decide to go down a slightly different path. Or if the patient doesn't agree with you and your tumor board, obviously you can offer the patient another opinion from a different hospital or whatever. But generally, the clinician whose case it is will transcribe the ultimate outcome, which is then put down in record.
Right. Do you have a follow-up of the tumor board consensus following the primary treatment? I mean, if you have got a decision for one patient in the tumor board and then has been executed, now do you have to follow this up in the following tumor board or as a follow-up?
We don't tend to. So for example, what we'll have is we'll have patients who've been referred in, okay, with essentially a CT scan. And the history is of say a rectal cancer with liver mets, okay, and the only staging they have is a CT scan. And we will look at the scan, and it'll either be, this is horrendous multi-site disease, you know, 100 liver mets, 30 lung mets, this is just palliative, that's our outcome, you know, then it's left to the local oncologist. If we assume that surgery, either to the primary or to the liver disease, is an option, then we will recommend for the staging. So that would generally be an MR scan and a PET scan. But we would also say, look, our recommendation in the whole in stage 4 disease would be systemic chemotherapy initially. And so we will do a follow-up MDT discussion where we will review that PET and MR and say, well, okay, are we still happy with the original plan, or has the PET and MR shown additional disease that maybe changes our plan? But then they will have their systemic chemotherapy completed, and then upon completion of that treatment, we have further imaging, and at that stage we make a decision of what we're going to do. Are we going to do simultaneous resection? Are we going to refer them for radiotherapy if it's a rectal cancer? Are we going to proceed with resection to the primary, or are we going to do the liver first, or whatever option that might be considered? I think in our tumor board, our medical oncologists are very conservative, and so certainly our clinical oncologists will always go with long course chemoradiotherapy for rectal cancer, which is margin threatened. So if they've got a large burden of liver disease, they'll have systemic chemo first, then long course, and in the window after long course, they'll have the liver surgery, and then subsequently the rectal surgery. But I know a lot of people are interested in short course. You can do short course first, then systemic, and then plan your surgery to the rectum or the liver, either staged or at the same time. So we do review imaging as it comes along. But for example, if I've done a resection, I don't, discuss the histology of the liver metastectomies in the tumor board. There's no point. But obviously, if on follow-up, the patient has recurrence, then that will get rediscussed.
Thank you.
So there's another question there.
Yes. Thank you, Dr. Malik. Okay, Dr. Hisham, I have two questions. First, do you record all the tumor board? That's one thing. Second question, that every cancer patient has to be passed through the MDT, or if there is a protocol for the service, and straightforward cases,
Yeah.
The surgeon will proceed for it.
Yeah. So
then is if there is dispute about what to do.
Yes, of course. So
two or more options.
Yes.
Do you vote, or you leave the responsible physician who is in charge of the case, who will choose which way to go?
Yeah. So in terms of so every case legally has to be discussed in the tumor board. All the discussions are recorded, so there is an electronic system. There are several versions of these systems, but the one we use is something called the Somerset Cancer Registry. So all the outcomes going back many years. I mean, we've been using that Somerset Registry since about 2010-11. So everything since then is recorded, and it's on the patient's records. The key thing about does every case need to be discussed in full detail, and that's an important point. So there was a process in England about 5 years ago where there was a process to try and streamline the tumor board, okay? And so as part of that, they did introduce this concept of standard of care pathways or protocols. So say, for example, the tumor board is about breast cancer, okay? And you're talking about, local breast cancer, non-metastatic, whatever. The treatment of breast cancer is very standardized, okay? And so a lot of these patients don't necessarily need a time-consuming complex discussion. So as long as there is a standard of care pathway that is agreed within the tumor board, a lot of these patients can be put into that pathway and can have their treatment commenced without a full discussion of the whole tumor board, but they're still registered as having been discussed and put into the pathway. But there isn't a full detailed discussion. The tumor board that I gave an example of is a tertiary tumor board for liver surgery, and every case that comes through us has a full discussion. Some discussions take 2 or 3 minutes. Some will be discussing for 5, maybe 10 minutes, because there is really a difference in opinion, and that is very challenging. Because you're the treating clinician, and your colleagues are all saying, we think this isn't the right thing. And what I would say to that is that sometimes I feel frustrated, okay, because I think I know what the right thing is, and then these guys are saying, no, you should do something different. But what you need to remember is that the tumor board is there to protect the patient and to protect yourself as well as a doctor. And if you, for example, have an outcome which is written down in the tumor board, and I have said it is advisory, it is something that once you met the patient, you can discuss the outcome, and you can adjust within some reason what you're going to do, but you'd be unwise to completely ignore the tumor board outcome, because if something goes wrong, you have no protection. There's a lot of medical legal problems we have in the UK, and so the protection you have as a doctor of having ignored the tumor board, goes, because then the lawyers will say, well, this guy is just making his own decisions and he's a loose cannon, you know. So the tumor board does protect you as a doctor, and also importantly protects the patient from inappropriate.
Do you vote for the decision?
We tend to, we don't put our hands up and vote, no. We tend to have a discussion, and at the end of that discussion, and there's a bit of a to and fro discussion, we come to a conclusion, you know. And on the whole,
but if no conclusion was committed for all of them,
yeah, but I think
responsible physician, if
yeah,
there is 2 or more options for
yes,
treatment, the responsible physician who is going to choose one of them?
yes, I think, well, so in that respect, I would say that what we would do is we put all, so this is where you have to annotate the information on the outcome very carefully. So if there are genuinely, the tumor board is split, okay?
Yes.
And one option is to go straight for an operation, the other option is to go for systemic chemo, let's say, for example, okay?
Yeah.
And there is a split there. Then when I do the outcome, I will make it clear that both options have been considered, right? And both options are valid, and we will discuss that with the patient. So it's important to document both.
Okay, the problem came when there is no class evidence for any
Yes.
decision, one of them.
Yes.
For example, it may be easy to say, for example, if you have a radical prostatectomy for Gleason 9 or 8 or something.
Yeah.
Some say that you do ADT or androgen, total androgen blockade for half a year, 6 months. Others say 1.5 years. And there is no class 1 evidence to choose one of them. And so there is a dispute in such. The responsible physician is the one who chooses.
Yeah, so well, so in that respect, I'm not I have no knowledge of prostate cancer myself. So
yes, I am simplifying it. I'm simplifying it.
Yeah, as an example. I think ultimately what I would do in that situation is to document, for the purpose of the tumor board, both options, discuss the risks and benefits for both. So for example, we have a patient in their late 70s who's got some health issues, who's got say a cecal cancer with liver mets, okay? Normally, we would say we would recommend systemic chemotherapy and then probably synchronous resection of the primary tumor and the liver mets. So that would be an example. But I see the patient, they're frail, they have a lot of comorbidities. You know, I discuss it with the patient, they don't want chemotherapy. As long as I document the tumor board said chemotherapy would be recommended, but having seen the patient, discussed the options of chemo and the morbidity of chemo with the patient, and we decide not to go down that route, I think that is okay, as long as you discuss things in a proper way. And crucially,
the patient will decide the final answer. I know that.
Yes, the patient often
the one
does decide.
Who has to consent. I know that.
Yes. Yeah.
But what is the role of the responsible physician?
So I think the role of the responsible physician is to discuss the case, to present the case, to do the outcome, but taking into account the views of their colleagues within the tumor board. And if there is genuinely a split decision, then that is documented, and the reason for the split is documented. And then you talk to the patient, you say, these are the two options, these are the risks, these are the benefits, what do you think? And you know what the patient usually says? The patient will say to me, what would you want if you were in my situation? And then I would say, well, I think I'd do this.
Oh, and so the patient is the final, has the final decision, you mean?
The patient has the final decision, but it's an informed decision based on the information that you give them.
Okay. Thank you.
But they often ask you as a doctor, what would you do? You know.
Yeah, I know that. Yeah.
You know, that's the thing.
Thank you.
No problem. Thank you.
Do we have any more questions from the audience? like that was the last question. Do you have a question to us?
No, I mean, I think this talk today is more of a thought-provoking talk. You know, it's not about whether you do something laparoscopic or open or how to do an operation. It's more about the toughest things in surgery are the decision-making, you know,
Exactly.
whether it's interruptive decision-making or decision-making as a whole. And I think it gives a bit of the background and the psychology of how we make decisions. And actually these good principles are also things that you can put into practice in your everyday clinical practice, not just in the tumor board, but when you're operating, if you're not sure, you know, call a colleague, you know, etc. You know, so it's about, it's just a good way of working, I think, you know, and that's why it's, that's what's important.
The MDT we only do in cases where we have debates. So like if you but as I understand, you do it in every case for medical legal issues. But if I send a straightforward case to the MDT, they will give me a look.
They'll think, well, why is
this?
This guy doesn't know what he's doing. Why is he sending this case to the MDT? Yeah. I get that. I do get that. But I think certainly in the UK, from a legal point of view, it's been this for many years. But even cases that you think are straightforward, it's you know, sometimes there's subtleties in the case. Also, the MDT is crucial for learning and education. And so it's important for the next generation. So we have medical students, we have other colleagues, registrars, whatever, who are in the MDT. And they learn a lot from the discussion. Even a simple case discussion can be very, you know, informative. And also crucially research. So recruiting people to clinical trials is important. I mean, the other thing to remember with the MDT and the tumor board is, you know, as surgeons, we often just focus on our last operation or the next operation, you know, and we think how great a job we've done based on that. But if you actually look at the whole burden of disease that you have, and the very small proportion of patients that you ultimately do an operation on, and the very few patients from that group who will then perhaps have a long-term cure, it is something that makes you reflect, you know, about our role in healthcare. You know, the biggest things that have improved the health of the globe are, you know, food, clean water, getting rid of war, and vaccination. You know, the surgeon doing a liver operation is a is a very small niche thing, you know.
Okay.
Excellent.
Okay.
Okay.
Okay. Thank you. It was a very nice talk, a cozy talk.
Yes, it's good to do something different.
Yeah. I enjoyed it.
Okay.
So thank you, Dr. Hassan.
Time, all the best.
Always a pleasure to have you with us, and Happy New Year to everyone.
Same to you.
See you next week.
Okay.
Thank you.
Bye-bye.
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 Bye-bye.